Hi, I'm Dr. Joanne McDonald. I'm with the Reproductive Mental Health Service in Dalhousie University in Halifax, Nova Scotia, Canada. This is one of a series of video learning modules that we prepared on maternal mental health or mother's mental health. So welcome, and our discussion today is going to be on postpartum depression. Postpartum depression is something sometimes that people have heard about, sometimes not, and in the United Kingdom is sometimes called postnatal depression. It's considered usually a depression that begins for the mother within the first 12 months after a baby is born. Sometimes the more likely periods are within the first 6 to 9 months for sure. Usually if a woman has symptoms past 9 months, they really began somewhat earlier, although she might not present for assessment or care until her baby is after 9 months old. The word postpartum is derived really from the word parturition, which is a medical term for the process of delivering the baby. 1 in 10 women will experience postpartum depression, and this has been found across many different countries, cultures, geographical settings, both urban and rural, both developed and developing countries, and is thought to be a pretty stable statistic. So this is often a higher rate of depression than most people would think is typical in a population of new mothers. And it makes it one of the most common complications then of childbirth is actually the mental health problem of postpartum depression. 60% of women who will develop a major postpartum depression won't have had particularly any formal history of mental health problem and certainly no previous diagnosis. They might have had some period of mood instability around period of stress or something more minor, but nothing that really stood out for them as particularly an illness that might put them at risk subsequently after their baby is born. Family and friends then may not expect postpartum depression. And it's pretty easy to put down some of the initial symptoms of depression after a baby comes to all of the stresses and changes and fatigue that can come with looking after a young infant. However, what are some of the signs that would suggest that this may be more of a depressive illness and less of a typical adjustment period? Well, an inability to rest when the baby rests. So a sense of restlessness, difficulty falling asleep, difficulty staying asleep, or even when they do rest, waking feeling unrefreshed, like they've not had any rest at all and not particularly ready to go back to the tasks in front of them. Do they find their mind as suddenly seeming to work much more quickly than typical or much slower than usual? And it can go in one direction or the other for in a particular woman, and someone will even complain of both, that at times their mind is racing on anxious or other negative themes, but at other times when they turn their mind to something they need to concentrate on, they feel like it's going slowly, that the actual working nature of their thoughts is slowed down. And so concentration, planning, decision making can be very difficult. They may say that they plan to be pregnant, they're very happy with the baby, they can see that the baby's doing well, but they still feel internally a low motivation towards the task sort of in front of them, even things they would normally consider pleasurable. So often we'll inquire and say, if a friend came by and wanted you to go out with her baby and you with your baby on a nice day, do you have the interest and the sort of motivation to do that? And is that something you would normally do? Are you normally a social person who would like that kind of activity? If you say, yes, I would like that, and yes, that should be a good thing, but it feels like moving a mountain to get myself ready to go and do that kind of thing, we may be looking at postpartum depression. So we really focus in on that lack of ability to enjoy the usual activities or people in their lives. Does their self-concept seem to change? So a woman that was previously fairly confident and fairly flexible in the situations that she could tolerate, does she now see herself or talk about herself in more exclusively negative or doubting terms? And does she really communicate some degree of hopelessness that doesn't seem to fit the situation that she's realistically in? Does she become overwhelmed easily in terms of coping compared to her usual sort of coping style in the past? And does she have unexplainable changes then in her sleep or appetite that seem, over and above what would be typical for postpartum moms? This is where other people's knowledge of the typical adjustments of pregnancy and early child care can really help a woman know whether her experience is really an outlier from what most women would sort of experience in terms of fatigue or bodily changes. And this is where frontline service and support providers really have a good sense of what is typical for young families and for new mothers. I'm going to do a little true and false with you now here around some statements. I want you to consider whether you think these statements are more of a truth or more of a falsehood. So postpartum depression is more common with teen mothers. Number 2, family history of postpartum depression increases the risk of postpartum depression. Mostly these depressions will lift with time, and it could be hard, but there's really no need to treat because the depression will lift. 4, it's better to cope without treatment for the sake of the baby or the child. And 5, there's very little a family or friends can do. This is really something a woman has to work through herself. It's about her biology and her adjustment. Well, in fact, in formal research studies, teen mothers have the same rate of major depression postpartum as older mothers do. Now, they may have more difficulties, though, with adjustment if their supports are few, and they may have increased social disadvantage, which predisposes any person to depression or other mental health challenges because of deficits in sort of education or income. But when they're matched for stressors, their income level, their levels of support, and their living circumstances, really they have no greater risk of postpartum depression. This can occur for any woman really at any socioeconomic status, educated, less educated, again, of any sort of culture and background. As far as number 2 goes, a family history of postpartum depression with what we call a first-degree relative, like your mother, your aunt, one of your first-degree cousins, really would increase your risk statistically for postpartum depression. But it's not a certainty that you'll develop that illness. But it is perhaps a little bit of a warning that if there is other women in the family that have postpartum depression, it might be good to watch for this. It might be good to think preventatively and proactively about what a woman needs to do to maintain good mental health. Up to 20% of untreated postpartum depression can become a chronic depression that will affect function and quality of life. So it's another factor to consider on balance when we're looking at severity of symptoms and the need to treat and what kinds of treatments are necessary. Because somewhere between 10 and 20% of women who don't receive treatment certainly will go on to have much more chronic difficulties. Untreated depression in a mother is also strongly associated, again in formal research and outcome studies, with a broad range of developmental measures for their children. So some 2 to 3 years out from the mother's experience of depression, if it's persistent, we can still see differences in those children compared to their age-matched comparative group in terms of physical growth, their capacity physically, the kinds of development that they have in terms of walking, their ability in terms of strength and coordination, as well as measures on speech and in language facility and also general cognitive or brain-based behaviors. So again, for those of us working with women with depression in pregnancy or the postpartum period, it really argues for us to look very carefully at who's ill and what kinds of treatments and interventions we can provide for them that will be effective and also safe for their unborn infants. Another consideration, of course, is safety of the use of any treatment for infants who are breastfed. High levels of social support, like from family, friends, neighbors, other mothers, professional caregivers in support roles, can really be quite helpful in preventing postpartum depression, sometimes in preventing its onset, but also in preventing the severity and improving the woman's sort of rapidity and the sort of fullness of her recovery. It's important also, though, to come back again and to acknowledge that the social determinants of health, such as housing, education, the quality of the neighborhood, nutrition, and overall income, really influence availability and accessibility of health care and have a lot to do with outcome for postpartum depression or any psychiatric illness. Here's a fast fact. Postpartum depression isn't always sadness, blueness, like we associate with the notion of depression. It can be a mixture, really, of unusual or dysfunctional moods. And they can occur sort of together, or they can occur in succession. So women will describe being unusually irritable, having a lot of tension and increased anxiety in both their body and in their thinking, as well as sort of a sad mood. And because it changes so much, sometimes that's more difficult to make the diagnosis, because it's seen as, well, I must just be reacting to whatever's happening today, or the baby didn't have a good nap, and so that's probably why I'm irritable and cranky. It's important to look at the overall pattern of mood, as well as those physical measures in terms of sleep, energy, appetite, and cognitive function to make a good diagnosis of depression. Why does depression risk increase after a baby is born? Well, we think part of it has to do with sleep deprivation, and we know that most new parents actually have a deficit of sleep compared to what was like for them sort of pre-pregnancy, for sure, and even within pregnancy. But we think that some people's brain chemistry is particularly sensitive to sleep quality and sleep duration, and for those people, that may be one of a number of triggers for mood dysregulation. Certainly, any kind of psychological stress can be a factor in why depression begins at a particular time, or why it begins for that particular person. And sometimes it's the combination of things that have been happening for that person in terms of major changes in role, relationship, and expectations of themselves, and that others have of themselves. So we always try to counsel anyone with a history or a risk of postpartum depression, to try and minimize the stressors that they can control. So not the time to make a move if you don't really have to, not the time to build a new home, not the time to take on a challenging sort of new job, those kinds of stressors that we can control. When a woman is pregnant, her usual coping strategies may not be as easy to do. And one in particular that you think about often is exercise. So many women, you rely on exercise, and regular, fairly rigorous exercise, as a way for them to, de-stress, a way for them to sort of regroup physically, and a big part of their emotional wellness plan. If you have any complications in pregnancy, let's say threatened preterm labor, that would suddenly limit that woman's ability to do any of her usual range of coping activities, or she moves away and she doesn't have the contact with family and friends, that's her way of sort of relaxing and regrouping. This may be a factor. But overall, we think that some women have particular vulnerabilities in their brain chemistry that's triggered by the hormones that change in pregnancy and after birth. And this is the factor that tends to be shared amongst family members. So this is probably the inheritable part of the risk of postpartum depression. Just as we all have sensitivities on any spectrum in terms of our body's function, the same is true for mood. Some strategies to prevent postpartum depression will include reducing stressors wherever possible, helping with tasks other than baby care, so bring in all the supports and help that you can, and even if they are not in a position to help with the baby, they can certainly help with the household, with laundry, with meal preparation. If they're older children, assist with their care. As well, though, it's still important even to have brief rest periods from infant care, even if it's 10 or 15 minutes at a time, when the mom can rest, regroup, do something of interest to her that's light, watch a television program, and participate in a leisure activity that she used to do, read something that's not too challenging. Those kinds of things are really important time out from the busy work of looking after a new infant and responding to their cues and their needs. Build in extra sleep wherever possible. Usually we say for quality of sleep at night, we encourage people not to nap if possible during the day. This is a little different for the postpartum mother. We really encourage her that even if her sleep is broken into 2 or 3 chunks through a 24-hour period, she should be still trying to get as much actual sleep as she can. Really consider active assessment and treatment of depression in pregnancy, because untreated, this will certainly progress in the majority of cases to deepening of a postpartum depression. Cognitive behavioral and emotional regulation strategies and therapies have also been found to be quite effective in the postpartum depressed population. What are some treatment options? Well, mindfulness and relaxation techniques really are good practices for any of us in terms of mental wellness, but can be particularly helpful in the maternal population in that postpartum period. Again, this could be one of those times that mom is taken out of her usual duties and given 10 or 15 minutes to concentrate on her mindfulness exercise, on some deep breathing or other relaxation strategies. Has to be given a priority along with all the other demands of a new infant. Physical exercise, including practice that increase relaxation and focus, can be particularly helpful, and again are often overlooked in the sense that the time, the space, the availability of that for mothers is not always sort of protected, really. And it's that, oh well, I'm pretty busy and I'm getting lots of exercise walking with the baby, or up and down stairs, doing laundry and looking after the children. But it may be very important that there's particular kinds of physical exercise that, again, that woman is very comfortable with, or that really allow her body to stretch, allow her to breathe deeply and fully in a way that can be an adjunctive part of intervention in postpartum depression. Again, if energy and motivation are low, it may be very difficult for a woman to exercise, on the spur of the moment at exactly the time that it's easy for her to do so. So making that part of a recovery plan can be really important, and looking at who the alternative child caregivers could be during that time. Antidepressant medications certainly are used with good effect and good safety in many postpartum women, including with safety for the breastfed infant. This is a complex area, and it always needs to be considered for that particular woman and that particular infant. And there are good resources which are listed in the toolkit to consider what medications we do have research on safety and tolerability for breastfeeding mothers. But again, this is always weighed sort of for the individual woman by her caregivers as to what the best balance for her is. But it should be known that it's not automatically that if a woman is breastfeeding, she can't be considered for antidepressant or anti-anxiety medication treatment. As well, depending on the feeding schedule, judicious and short-term use of sleep medications can be very helpful to get the mother's sleep pattern back on track, not expose the baby, who may still be breastfed, to too much medication effect or sedative effect, and really help the whole family to settle and begin to improve. We're also strong proponents of nutritional enhancement with natural foods where possible, but at times supplementation with substances such as omega-3 fatty acids may also be part of a comprehensive and holistic treatment plan. Who can help? Well, number one, always family and friends. People say, well, women will say, I don't really want to burden anyone, and they make the assumption that this is a burden on other people, as opposed to perhaps other people sense that they'd be happy to participate in the care and the start in life for this particular infant. Sometimes help and support can come from places that people didn't sort of expect. There may be a relative they don't see so often, there could be a friend, there could be a neighbor who's quite able and willing to sort of help out on a short-term basis. We always encourage mothers to understand that they have the long-term 20-year plus job of becoming a parent to this infant, and that other people will really be very part-time workers in this effort, and that it's not always a burden. Another important source of help, obviously, is a partner. If that person, he or she, is present in the life of the woman who's suffering from postpartum depression. Again, sometimes there's an assumption by the mother, this is my job, I'm on maternity leave, I should be able to do this all by myself. My partner has to get up and go to work in the morning. I really can't burden them with anything more. But it can be a very important time for the couple to communicate about what's happening and understand that if they have a long life together, there will be many times in which they need each other's support, both emotionally and in terms of practical help. Fathers often comment, and partners often comment, that had they known more about the possibility of postpartum depression, they would have been readier to look for the signs, and they would have understand why they needed to sort of step in and provide a bit more in the way of support. And that it's not necessarily typical of the adjustment to a new baby that everyone is struggling. The role of the primary care physician or nurse practitioner or health care worker in a collaborative health center may be very important in terms of beginning that initial assessment of whether there's possibility of postpartum depression, and then looking at what kinds and mixture of interventions might be best for this particular woman. Again, mothers supporting mothers are really critical to adjustment to caring for an infant in general, but particularly in the setting of postpartum depression. And other women who may not necessarily have had exactly the same experience, or may not necessarily even had an illness as such, but understand sort of the context of mothering, the kinds of adjustments that are necessary even when there is no postpartum depression, can be very helpful social outlets to a mom who is struggling with her own confidence and her own self-concept. Community support workers, such as family resource center workers, parent educators, and community health workers, can be in a really important position to recognize the signs and symptoms of postpartum depression, to advocate for assessment and treatment, and support that woman indirectly in her process of sort of recovery, reassuring her that they've seen other people who with this kind of illness, so they have recovered and they've gone on to be very successful and engaged parents. Because in the tougher points of a postpartum depression, women often lose their belief in themselves and their hope for the picture that they had of their family life in the future. Obviously, in some instances, there will be the necessity to involve a mental health professional as well, and this may be in an assessment role, a counseling or therapy role, monitoring for symptoms and response to medication role, and a more comprehensive psychiatric treatment role. Some women may get engaged in formal programs, others may see an individual practitioner, again depending on the availability of services in a given region and what fits for that woman and her capacity to attend appointments. It may need to be sort of flexed as best as possible. What can help? Well, besides professional care and all the supports we mentioned, there's really important impacts of self-care. So all the best medicines in the world, whether it's in mental health care or physical care, really are not going to work very well if the patient isn't practicing good self-care in terms of, again, their daily rhythms, their nutrition, their regeneration of their body through sort of rest and relaxation. There are also a number of self-directed recovery strategies and programs, and a couple of those are really mentioned in the key resources listed below. So postpartum.net is a website that's really sponsored by a group called Postpartum Support International, which is a patient or consumer-directed advocacy and education group with a broad range of professionals, healthcare professionals involved as well. So that can be a great resource and has some information for partners as well. The British Columbia government has a great mental health website called heretohelp.bc.ca, and within that you'll find links to many other resources for women in general and particularly for reproductive mental health. Also, you can access the BC Women's Reproductive Mental Health Program site through the BC Women's site. The hospital site itself, it's a little bit of a journey. You have to click on services, then on health services, and then on reproductive mental health. But within that website, you'll find that they have a very particular resource, which is a self-directed cognitive behavioral therapy, sort of manualized kind of approach, which really looks at how to cope with depression in pregnancy or the postpartum. It's an excellent resource. What's the outcome for women with postpartum depression? Well, it's really pretty typical that they have full pre-baby recovery if they've been, effectively and thoroughly treated. However, that recovery can come slowly for weeks to months, and that, time frame needs to be realistic in the mind of both the woman herself and her family and caregivers. Self-care strategies, though, and stress reduction may need to become lifelong habits to sort of limit any recurrence risk of depression, and are good sort of, health habits to consider in general to maintain our coping, maintain our emotional regulation, and our general sort of resilience. Many women worry because they feel so disconnected generally in the wake of a postpartum depression if they're going to really have full attachment and to their infant, and will there be any effects for the infant. research would tell us that without treatment, there are certainly great risks for continuing depression for children in terms of their attachment function as well as their physical and emotional and cognitive development. However, with treatment and a lot of support around attachment, most women and their infants really will stay quite connected and be able to sort of thrive going forward. So postpartum depression doesn't need to become a risk for the vulnerable infant. What's a woman's risk for depression after her next pregnancy if she's had one episode of postpartum depression? What do you think that is? Well, the risk the first time, remember, is 10% or 1 in 10, and the risk for a second episode after a second pregnancy is 20%. So you have to remember that in two ways. Although you can say, well, the risk doubles if you've already had one postpartum depression. If you've had a postpartum depression after your next pregnancy, you still have an 80% chance of remaining well. And again, you're already prepared that this could be a risk for you, and you may be able to mitigate some of that risk, again, by those good self-care and stress reduction strategies, and having a plan with your family and caregivers as to how you're going to approach intervention and treatment should you begin to have those early symptoms. So you won't be so quick to dismiss them and say, oh, I think it's just a bad night's sleep, or I'm just not adjusting. You'll think, I've been here before, this could be major depression again, and you'll be quicker, I think, to access assessment and treatment. So important take-home points are that community service providers can be critical as sources of support, recognition of a woman's struggle and knowledge of local resources, and providing leadership in reducing stigma in mental health care for mothers. Postpartum can be a serious but ultimately very treatable illness and have a really good outcome with care. So overall, that's the message we want people to know. Be on the watch for this. It can occur in 1 in 10, but this is a treatable problem. We need to all get on it fairly quickly, support that mother in full recovery, and the outcome is, in the vast majority of cases, likely to be quite good for both mother and infant. So again, thanks for watching our learning module, which is in a series developed within the Mother's Mental Health Toolkit project, and the aim is to promote knowledge and advocacy for mothers' mental health care through frontline service and support workers. Thanks again for your time and attention.